Good afternoon, everyone. My name is Sarah Gikonyo. I'll be your moderator for today. Today's topic is in light of nutrition in pediatric oncology with Barbara Muliro, who's a clinical nutritionist at Kenyatta National Hospital with massive experience in pediatric oncology. Without further ado, I'd like to welcome everyone. And Barbara, kindly key in your questions in the Q&A section. We'll handle them after the presentation. Thank you.
Hi, everyone. Thank you for joining. Mentioned, we will be discussing nutrition in pediatric oncology. So why are we looking at pediatric oncology? First of all, we need to appreciate that pediatric oncology involves quite a number of nutritional challenges to the patients. Then we also know that malnutrition will have an impact in terms of tolerance, in terms of also how they'll be able to tolerate the treatment. It also has an impact on the recovery and the survival of our patients. So the aim of today's discussion will just be to highlight key aspects when it comes to nutrition assessments, and also to look at the nutritional interventions that we apply when it comes to pediatric oncology. So objectives of today's study will be, first of all, to understand the role of nutrition in cancer outcomes. We would also like to identify the different tools that we have for nutritional assessments, and also to be able to tailor the intervention of explore tailored intervention approaches to pediatric oncology. So when it comes to pediatric oncologies, these are some of the most common types of cancers. We have the liquid cancers, basically the blood cancers, such as ALL, we have the AML, we have the brain and spinal cord tumors, such as medulloblastoma, gliomas, ependymoma. We have the lymphomas, Hodgkin's and non-Hodgkin's. We have solid tumors, the Wilm tumors. We have neuroblastoma. We have retinoblastoma. We have rhabdomyosarcoma. And then we also have the different types of bone cancers, such as the osteosarcoma and also the Ewing sarcoma. So when it comes to pediatric nutrition in oncology, we have various factors that can contribute to malnutrition in these children. So we'll be looking at some of the factors, such as the disease-related factors. We look at tumor location. When it comes to tumor location, we have various types of cancers, as we've seen in the previous slide. So, for example, if a child has head or neck cancers, this may affect the chewing. It may also be able to affect the swallowing. You find probably for brain tumors, the swallowing reflex will be able to have a problem, and the child can't be able to swallow. Then they also tend to have increased metabolic demands, of course, because of the cancer being highly catabolic, because of all the inflammation that is also happening in the system. So you'll find it puts them at risk of developing malnutrition. Then we also have the various systemic effects of cancer, such as the chronic inflammation, the release of the cytokines, which can also lead to malnutrition. When it comes to also treatment-related, we look at the various effects of the chemotherapy or even the radiotherapy, such as the nausea. We have vomiting, we have diarrhea, we have things like mucositis, we have taste alterations, and the patients sometimes develop anorexia. And you can see that all of these may have an effect on the child, and they may be able to develop malnutrition. We also look at patient-related effects, such as age. One thing we need to understand is that for most infants and also for young children, they tend to be at very high risk of developing the older adults and children, because the they tend to have less nutrient stores, so the reserves are very small and become very quickly depleted. So developing malnutrition for them is very easy or very fast. Then they also have the pre-existing nutritional status. Sometimes we find most patients will come with a late diagnosis. So by the time the patient is coming, you find the patient is wasted. So yeah, already. So even before prior starting treatment, you find the patient is already having undernutrition. Then we have also poor oral intake, which is associated again with the tumor and also can be associated with the type of treatment that these children will be able to receive, which we'll be able to see a bit later in the presentation. Then we also have psychosocial issues for some of these children, being subjected to injections almost every day, seeing white lab coats almost every day. It also tends to affect them also psychologically. So you'll find sometimes it may also affect how they eat, even just being away from the environment, the home environment can also affect them. We look at the social economic status of the children or the families where the children are coming from. So this will mean that if there is low income, then you'll find the patient will be able to have limited access to foods that are nutrient dense or even the right foods, again, which can lead to malnutrition. We look at cultural feeding practices. There's some practices you find with some restrictions in terms of foods, which could also lead to development of malnutrition. Then we have also the clinical complications that could worsen malnutrition. These patients tend to have a lot of neutropenia, and you'll find the risk of infections are very high. The risk of gastrointestinal complications are also very high. Things like diarrhea, having the constipation, you'll have yeah, having even the frequent blood transfusions, and all these you'll find you'll be able to affect the children. So when we look at the effects of malnutrition, so when we have malnutrition, we talk about not just undernutrition, but we talk also about overnutrition. So both undernutrition and overnutrition for pediatric oncology patients tends to have a risk. So when we talk about the treatment-related effects, first of all, with especially wasted patients, you find they'll have a reduced tolerance to the chemotherapy and also to radiotherapy. This will mean that you'll find them having higher toxicities and also higher side effects. With higher side effects, you may find that maybe patient needs a dose reduction, or you may find sometimes patient is not able to recover between the different cycles of chemo, which leads to delays in terms of treatment. And this will, of course, affect also the effectiveness of the treatment that the patient is able to get. And one of the things that we have to appreciate is most pediatric oncology cases are actually very treatable. So we wouldn't want nutrition to be one of the things that would hinder the treatment of the child. So then we also look at the increased risk of infections. Remember, if your child is not having good nutrition, then also the immunity will be weakened. So when we have immunity weakened, then we have the higher risk of bacterial and also developing viral and also fungal infections. You'll find the child also having frequent episodes of febrile neutropenia and also having the prolonged hospital stay. And most of the time we would want this child to be able to go home as soon as possible, not to have to sometimes you find the patient is discharged, but in the course of treatment, because of having a weak immune system, the child gets sick again. So you find the child's discharge is then revoked. So the child ends up staying in the hospital for a much longer time. We also look at the growth and development. So you'll find that these children are still developing. So they stand a very high risk of developing stunting. And we know with stunting, we'll have, of course, the linear growth will be affected, but we also remember also the cognitive development of the child will also be affected. And we don't want complications after survivorship, we would want to reduce any nutrition-related complications for survivorship for these children. So we also look at the disease prognosis and also the survival. So with better nutrition, you find the chances of the disease prognosis and also the survival is also is improved, and it's much higher as opposed to if the child has malnutrition. It also helps to reduce mortality that can be brought about in terms of the kind of treatment that most of these patients will be able to experience. When we look at the quality of life also for the survivor. So you find maybe in the first 2 or 3 years of life, the child was not able to get sufficient nutrition because of the treatment they were going through. Then once they survive, you find the quality of life is reduced. You find maybe school attendance is much lower, maybe the cognitive function, because during the development ages, the age of development, you find the child was not getting the sufficient amount of nutrients that they require. So when it comes to looking for malnutrition, we need to have different ways of first of all, being able to assess if our patient is having malnutrition. We need to also be able to assess if our patient is at risk of developing malnutrition. So we look at the different methods that we usually use. The anthropometrics, we have the biochemical, we have the clinical, and we also look at the diet history of the patient. So through the anthropometric, we have various growth charts. We also have the BMI for age, the MUAC, which you'll be able to see ahead. We also have the biochemical blood markers that we need to look out for, and also the clinical signs of any malnutrition. We also need to look at clinical signs of any treatment effects that could affect or that could lead or contribute to malnutrition. Then we also look at the diet history of the patients. So when it comes to anthropometric assessments, there's no one assessment that we can say works, but we need to be able to make sure that we're able to combine several assessments. So we have the weight for age, we have the height for age, we have the weight for height, we have the body mass index for age, and we also have the MUACs. So most of these assessments, we have the WHO growth charts that are available. And usually we have various apps such as the AnthroCalc, which has various charts, including also the CDC charts and also the WHO charts that you can be able to use to be able to chart or know the nutritional status. So this is just a sample of some of the growth charts that we have. So when you're able to log on to WHO site, you'll be able to find each and every one of these in terms for weight, for age, you look for the height, we look for their BMI, we are able to identify the tables from there. So when it comes to anthropometrics, as we have mentioned earlier, we can't go by one method. We can't go by the height for age or weight for age or one. We need a combination. And in some of these patients, especially for solid tumors, you'll find most of the weight will not be accurate. So if you use some of the weight for height measurements, you'll find that you will misdiagnose malnutrition, or you may not be able to identify. So we have various cutoff points for different ages. This is for MUAC. So in the case of solid tumors, you would preferably go using the MUAC as opposed to using the weight or the height. So we have an example here of a patient who has Wilms tumor. So the date of birth of our patient is the 28th of February, which is 2018. His weight was 23.4, a height of 129.9 centimeters, and he had a MUAC of 11 centimeters. So as we can see, our patient is 7 years old. So when we calculate the height for age, I used the AnthroCalc calculator to be able to calculate his height for age. So it gives us that the height for age is normal. So meaning our patient does not have any stunting, which could be a sign of chronic malnutrition. When we look at the BMI for age, the Z-score is negative 1.38, which is actually normal. But when we look at the MUAC, and if we look at the table, our child is 7 years old. So if we look at the MUAC table, for a child between the ages of 5 to 9, anything less than 13 centimeters is classified as severe acute malnutrition. Anything between greater than 13 and less than 14.5 is MAM, and anything above 14.5. So for us, our target with this patient is to have a MUAC of above 14.5 centimeters for us to classify that the patient has normal nutrition status. So if you look at other parameters, they seem to indicate that the child is normal, but when we use the MUAC, we are able to see that the child has severe acute malnutrition. So we also have other considerations that we have to put into mind. So some of these patients you'll find, for example, with osteosarcoma, or some of these masses you'll find have to end up amputated. So this is an example of one of the patients that we had who got an amputation. So remember, once a limb has been removed, then the weight will not give us the total weight of the patient because it's minus the limb. So the patient in question here actually had his whole right leg amputated. So when you do his weight without, post-amputation is 26.9 kilograms. We look at his height was 131.8, and he had a MUAC of 20.8. So one thing we need to appreciate the MUAC, because the child is 8 years, is about 14.5. So a child is having normal nutritional status. So there's a formula that is used for correcting the weight of a patient who has amputation, and this is based on the degree of amputation that the child had. So for our child, the whole right leg was amputated up to the hip. For us, we were able to use the 16%. If you have ankle amputation, as we can see, you use 1.5. If one is amputated up to the knee, we'll do 1.5 plus 4.5. If it's the whole leg, it's plus 10.1, which gives us a 16. So this is normally used to be able to correct the age, the weight of a patient who has been amputated. So if we look at the corrected weight, if we look at the corrected weight of our patient, we can see that the corrected weight is 32. We can see that the corrected weight is 32 as opposed to the actual weight that we got when he was taking the weight, which was 26.9. So when it comes to biochemical tests, we need to look at various things. First of all, we need to look at complete blood counts. The blood counts are going to look at the things of interest. First of all, is looking for anemia, looking for platelets. Again, we can be able to tell if our child has neutropenia. Of course, if our child is having neutropenia, then it means the risk of infection is very high. Hygiene must also be maintained very highly. When we look at something like platelets, for example, if we are considering fixing an NG tube and the platelets are low, we cannot fix it in case of bleeding. So it will be contraindicated. Then we look at things like the serum and the prealbumin. So most of the time, sometimes we'll find when a patient is admitted, the first thing we look at is albumin. When the albumin is low, we'll be very quick to say maybe the patient was not taking sufficient protein. So one thing we need to appreciate is that cancer is very inflammatory, and as long as there's inflammation in the body, you will find that most of the time the albumin will be low. So albumin is usually not a very good indicator of malnutrition or low protein intake. So in case we also want to target albumin, or a patient comes with low albumin and we're trying to increase the albumin, sometimes we'll find we will do the albumin infusions. You'll find maybe we've modified the diet, then you become frustrated because the albumin is not coming up. We need to also appreciate that the albumin tends to have a half-life of 21 days. So it's prior to 21 days, it's not going to reflect on the blood in the biochemical markers. So prealbumin tends to be a better indicator, but it needs about 2 to 3 days before we can be able to see. So it's a better indicator, but the challenge is that the cost of doing some of these tests and also the availability of some of these tests are not there. Then we also have to look at the renal and to be able to look at the functional, the liver and the renal function. Now, one thing we need to understand, so for some of the patients, especially those with renal tumors, such as the nephroblastoma or neuroblastoma that's affecting the kidneys, you'll find the children with very elevated blood pressures. So sometimes a dietitian will think that I want to reduce maybe the sodium content to be able to reduce. So one of the things we need to appreciate is that we need to look at the renal function. I cannot put an intervention based on the BPs are high. I need to be able to understand how is the kidney functioning working. So most of the patients with liver masses, you tend to find the BPs are elevated mostly because of the tumor pressing on the adrenal glands, as opposed to it being the functionality of the renal of the kidney. Then we also look at various micronutrients such as iron, we look at zinc, calcium, phosphorus, and also vitamin D. And we also look at the C-reactive protein. As I had mentioned earlier, that when we have inflammation, albumin will decrease in the body. So if your CRP is high, then this will definitely tells us that there's some inflammation. And of course, we'll expect that probably the albumin will also be lowered. So the CRP will be able to help us tell that. Then we also have to be able to check the blood sugar. Some of the chemotherapy regimens that the children are put on, for example, patients with ALL will be put on steroids, and at the same time they tend to receive one of the medications known as L-aspa, which tends to elevate the blood sugars. So we also need to make sure that we're monitoring the blood sugars to be able to change the diet as required. When we look at the clinical side of the patients, first of all, we want to determine what type of cancer does the child have, what stage of cancer do they have, and also what kind of treatment they will be experiencing. So the type of cancer definitely will affect how the child will be able to react. When you look at clinical treatments, is a child having nausea? Is a child having food aversions? Are we having changes in taste? Are we having constipation? Are we having anorexia, which could all come as part of the treatment? When we look at the cancer type, for example, if we have solid tumors, you may find, is it pressing on the stomach, which definitely will reduce the amount of food that a child is able to feed. Then we also look at the stage of the child. Then we also want to look at any signs of malnutrition that we may be able to look at. You look at probably do you have the bilateral edema? Look at the hair changes of the child. Look for any signs of malnutrition that could show you whether it's chronic or even if it's acute malnutrition. We want to be able to also look at any GI symptoms that the child may be experiencing, the nausea, vomiting, diarrhea, the mucositis. We also want to look at infections and also the inflammation that may be able to affect the nutritional status. So when it comes to dietary, we have various methods that we need to take. So we can take the 24-hour food recall, which is just trying to ask the mother what has the patient taken for the previous day. So the challenge with doing a food recall is many times you'll find the mother is unable to remember everything that the child will be able to had taken even for the previous day. Of course, sometimes you'll find some of these mothers are very stressed. So but they may not be in a very good position to remember. Then we also have what we call food records. So food records are a bit more accurate and can be taken up to several days. So for a food record, you just ask the mother to have a piece of paper and pen. And then anytime that the mother gives the child any type of food, the mother needs to record. So she records the time, then she also records the type of food taken, and also the amount of food that the child was offered. Then we also have to make sure that when we are looking at the diet, we need to look at the food preferences. So most of the time you'll find these patients, once they receive chemotherapy, you may find they have a tendency to crave certain foods and may also refuse other types of food. So taking a diet history is very, very important. Then we also have to look at, does the patient have any dietary restrictions? What about the culture? We still need to make sure that we're respecting the culture of the individual. Then we look at the adequacy and also in terms of energy, what are the requirements of your child? What what amount of the requirements of your child is the child able to meet in terms of energy and also in terms of protein needs? So once we know this, then it's also able to guide us in terms of the intervention that we need to put in for the patients. For example, does my patient need an NG tube to be able to increase the kilocalories? It also helps us see if my patient is meeting this amount of nutrients, how much do I need maybe to top up in terms of supplementation, or how can I be able to support the patient to be able to meet the caloric requirements. So when it comes to intervention, first of all, we need to make sure that all our interventions are based on the assessment results. So remember, if we get our assessment wrong, then it means the overall conclusion is wrong. Then it means also the type of intervention that we do may not be able to be appropriate for the child. So we need to make sure that all interventions are tailored towards the needs of the child. We need to look at the various oral nutritional supplements that, does my patient need supplements? How much supplement does the patient need? Could I maybe be in a position to provide fortified foods, such as fortified porridges, that maybe can be able to meet this gap? We also need to look at, does my patient need enteral nutrition, that is tube feeding for adequate intake? So one of the problems we tend to have, especially with enteral feeding, is if your patient is not meeting sufficient kilocalories, especially for children, you'll find it's much better for one to be able to fix an NG tube for the child to be able to meet caloric requirements. So most of the challenges you'll find will come from the mother, and sometimes it comes from us as healthcare workers. You find we're not maybe very ready to fix NG tubes to be able to feed the child. Yet you find the child is not getting adequate nutrients, and it's not the mother's fault, it's not the child's fault. And the only way to be able to get some of these nutrients is maybe through the tube feeding. So tube feeding is not a punishment, it's more of a way of helping the child to be able to get adequate calories, to be able, of course, to sustain their growth. And it is much, much easier because you're able to calculate the caloric requirements and you're able to deliver them even through intervals. The child can be fed throughout 24 hours as opposed to maybe the few hours that the child is awake. And sometimes you find some of these children, because of the effects of the cancer, some of the drugs they're on, you find they're very tired. You find maybe they're sleeping for long hours, meaning they have very limited times where they're awake and where they're feeding. Of course, we will not be in a position to meet caloric requirements. Then we also have the parenteral nutrition. Sometimes you have to monitor. I can give you like the example of a case. We once had a patient who developed diarrhea for about 3 weeks. It was persistent to the point that if you would put anything through the child's mouth, within the next minute, you find the child is passing stool almost immediately. So you'll find for such a case, a patient would require parenteral nutrition. So you need to be able to tailor your interventions based on the requirements of the patient. Then again, you need to give a lot of education. You need to support the caregiver as much as possible. You will never make headway if the caregiver is also not supported. You need to be able to explain to the caregiver the importance of the nutrients, and even like where you will need to put the enteral feeds. You need to be able to even support them even psychologically and everything. Yeah, then we also need to make sure that you're doing a lot of feeding counseling, and you'll find that this one has to be consistently done because things will change and the patients tend to react very differently. Then we look at the goal. What are you aiming for when you're doing your interventions? Sometimes you may aim to maintain weight. Sometimes you may be able to aim maybe to gain weight. Yeah, so you have to be able to just tailor your interventions based on your needs. So when it comes to chemotherapy, we have various effects that you find have a lot or can affect the feeding of a child. And most of them come from a number of the chemotherapies some of these children receive. So when we look at the nausea, vomiting, which tends to be one of the most common causes or issues that most of these patients will experience, and most of the time you find as we've mentioned, it's good to know the type of cancer the child has. It's also good to know the kind of treatment the child has, so then you can anticipate the kind of reactions that you would probably maybe expect. So when we have the cisplatin, the cyclophosphamide, doxorubicin, actinomycin, methotrexate, dacarbazine, these ones are very, it's very common for them to cause the nausea and also the vomiting. So first of all, when we want to do the combinations, we need to make sure that our children, first of all, on antiemetic therapy. So most of the time, like the practice we have in the ward is prophylactically. By the time they are given the chemotherapy, they're also given antiemetic therapy for those chemos where you find the child will be is at risk of developing the nausea and vomiting. Sometimes you may need to give the child cold foods, and also in small, frequent feeds, encourage them to eat slowly, avoid strong odors, foods with strong odors. You need to make sure that the child is taking fluids in between meals and not with the meals or during the meals, so that the child is able to eat as much as possible. You find that the amount of food the child will take will be reduced. Sometimes, for example, maybe you can make a smoothie or juice and you give the child to take it with a straw, and you make sure that you cover the cup or the plate so that the child is not able to smell the food. So some of the issues you'll find sometimes your child is feeding very well and there's a food they love. Then once they receive chemotherapy, they actually do not want to see that food. And some of them, they'll tell you, oh, the food is smelling really bad. It's just an effect of the chemotherapy. Then we have the things like diarrhea, the actinomycin, adriamycin, methotrexate. Sometimes the child is on a lot of antibiotics. Remember with neutropenia, sometimes most oncology patients are ever on antibiotics because of the risk of infections that they have. So we need to make sure that also the mothers maintain very high hygiene. We ourselves also maintaining high hygiene. And then we also find sometimes the children will get neutropenia. So if the hygiene is not maintained, then the child will develop diarrhea. So for diarrhea, first of all, we need to make sure that the patient is well hydrated. We need to make sure that the child is also, sometimes a clear liquid diet may be more tolerant compared to a normal diet. So we need to also consider, probably like in the previous case I had mentioned, if our child will, if TPN may be able to serve our child better. But this is in very severe cases of the diarrhea. So one of the things we also have to remember is even as our child is on antibiotics, sometimes it may affect the the normal gut microbiome. So we may be able to have alteration. So sometimes the diarrhea may not necessarily be from the chemotherapy, but could also be maybe the antibiotic treatment that the child is able to have. So we need to make sure also that the child or the mother make sure that anytime the child is having the diarrhea episodes, in case the child is on a diaper, we need to make sure the mother is keeping the rectal area clean, and we also need to make sure that it's kept dry to prevent the child from getting any sores or any burns that could affect the child. Then we also look at constipation. Some of the medications that these children are given, such as the vincristine, tends to cause the constipation. Some of them also, because of the very severe pain they are on, you'll find are also on the things like morphine, very strong painkillers. So again, some of these patients you'll find are bedridden and not moving around. So chances of them developing constipation are very high. So most of the time you'll find, first of all, they will need a high fiber diet. Again, sometimes if they're able to do some form of exercises, when the children are much better, sometimes they should be encouraged to walk around, play with other children when they're able to, because this movement will also help. They're also put on things such as lactulose to be able to help with the constipation because of the pain medications. Sometimes you may find maybe because of the environment that the child is in, when you're used to your home toilet and then here you're in public, you have to go to the toilet in the room where there are other children. You may find maybe the child is not comfortable. So sometimes it may call for you to maybe find privacy for the child. That is just in case they need it. Then we also tend to have the altered tastes. Vincristine, the carbazine, the cisplatin, cyclophosphamide, and also antibiotics tend to have altered tastes. So very proper oral hygiene is very, very important. And also trying to make sure that the child mouth is more moist by constantly giving fluids. We will also want to avoid anything with very strong very, very strong smells. Probably we would try to try things with different types of tastes, maybe fried, different cooking methods if it's possible. We would also try to maybe, for example, enrich your foods using spices, for example, just to see if the child will be able to eat. You can offer even foods that are slightly salty, or maybe slightly acidic, maybe such as the fermented porridge, and just if the child is able to tolerate. Then we have things such as the anorexia, which can be caused by a number of things. First of all, again, remember for some of the tumors, depending on the location, they may be able to press on other organs, or sometimes it may be pressing on the stomach, which of course will make the amount of food that the child can tolerate to be minimal. Again, the patient sometimes will have difficulty breathing. Our child will not prioritize feeding. Sometimes with difficulty breathing, you find if the child was on breast milk, now they're unable to breastfeed or they don't want to breastfeed. Once the difficulty in breathing has subsided, then you find the child is able to breastfeed again. Sometimes because of the altered tastes that these children are experiencing, they may not want to eat. Sometimes you may find them asking for certain foods that actually normally they would not eat. And the foods that they will normally eat are the kind of foods that they don't want. Then we also have the constipation. Sometimes the constipation can bring the fecal impaction. The child will be having a lot of gas, feeling of pain in the stomach, will find a feeling of fullness. Of course, the child will not feed well. Then again, sometimes if our child is having a lot of diarrhea, you'll find because of some of the pains that they're experiencing in the stomach, the child develops anorexia. They don't want to feed, or you'll find they eat very limited amounts of food. Then we also have the nausea and vomiting. Now, one of the things I think I should mention is most mothers will feel very frustrated, but they may not be able to identify what the child is going through. So when the mother is frustrated, you'll find them trying to force the child to feed. They'll beat the child, threaten the child, open, close the nose of the mouth so that the child can swallow. So the challenge with this is when the child is fine, they may have issues with food because of the traumatic experience that they had when they were not well and the mother was forcing them to eat. So one of the things is we need to try and encourage and ask the child maybe what it is they're able to tolerate, or maybe what it is they're able to eat. But at the same time, we just try and encourage them. Then we have the mucositis, which is very common with actinomycin, adriamycin, daunomycin, the rubicin, the bleomycin, melphalan, and also high-dose methotrexate. So when a child develops the mucositis, first of all, the child will not be able to push something in the mouth very easily. Sometimes it may be along any part of the GIT. So the child may also have pain on swallowing. So first of all, it's very important to make sure that the child is on pain medication. Again, we have various methods that we could try to use in order to be able to prevent some of the mucositis from developing. So we have various methods that have been used, first of all, such as cryotherapy. So during cryotherapy, we encourage you to give the child ice cubes or cold ice cubes. So most of the time, this should be done when chemotherapy is running. You can take it a few minutes before chemotherapy and during chemotherapy, something cold. So this tends to help them prevent damage to the. It helps constrict the blood vessels and helps reduce the damage that it may have on you may be able to have on the mucosal lining. Then we have the honey again that can be used for prophylactic treatment. So you can take around 25 mLs of honey, which you dilute in water, and you have the patient gargle it. They swish it through the mouth at least 2 to 3 days prior starting chemotherapy, and also during the chemotherapy, and for up to at least 2 weeks. That is around 14 days for after chemotherapy. So the viscous nature of honey tends to help also soothe, and it also tends to have some microbacterial properties. So one thing we need to remember is that we do not advocate for use of honey in children below 1 year. And because of the neutropenia, we need to make sure also that we are using pasteurized honey for the safety also of the child. So sometimes even if your child has the mucositis, you can also encourage them to take the honey. The honey, if your child is unable to swish and maybe swallow, you can always put it in some of the liquids that they take, such as the water. You can put it even in yogurt, something that the child is able to take. Then we also have the prescription of glutamine, usually calculated at 2 grams per meter squared. And normally you put it in a beverage of choice, at least 200 ml. You wash it and then you swish it again also in the mouth for 30 to you hold it in the mouth, swish it for at least 30 to 1 minute, and then you swallow. So ideally this should be done on the first day of chemotherapy and for up to 14 days until from the last chemotherapy dosage that the child receives. So one of the things is most chemotherapies tend to target the rapidly dividing cells, and this tends to be along the gastrointestinal tract. So glutamine tends to, we know it's one of those conditionally essential mineral amino acids, one of those conditionally essential amino acids. So when we do it, you find it tends to help the regeneration of the cells. So that is why it's found to almost help prevent and also to be able to treat the mucositis. The mucositis. Yes. So then, based on discussed in conclusion, we've been able to look at the assessments, how we do the assessments. We've been able to look at biochemical factors that we look at. We look also at the clinical factors and also look at the dietary factors that can help us. So first of all, early detection, early nutrition assessment, and also continuous nutrition assessment throughout treatment is very, very important for these patients to be able to tell in case your patient is losing weight, in case your patient is gaining weight, of course, depending on the goals that you have for the patients. Again, as usual, the ABCD assessment helps us to it helps guide us to be able to make sure that we have individualized intervention for the patients based on the requirements of the patients. Then we also need to appreciate that collaboration between nurses, the oncologists, even the nutritionists. We need to make sure the caregivers, the whole medical team, and also the caregivers. It's very, very important because especially for children, there'll be the ones who will be very key in terms of implementing the interventions that we have put in. And then we also have to remember that when we're dealing with pediatric patients and oncology, the nutrition will help enhance their chances of survival. It will also improve their quality of life and also in terms of long-term outcomes, because we need to remember that our children are still growing. So we need to make sure, despite the treatment that they're going through, that the normal growth will be able to continue. So those are my references, and thank you.
Very much, Barbara, for the strategy. We have seen different types of chemotherapy medication, and now we'll go through the questions in the Q&A. Kindly you can type in your questions as we start responding. Thank you. So there's one question by Victor. He's asking if a patient is not able to take adequate feeds enterally because of painful mouth sores, is it in order to assume the other parts of the gut mucosa have similar injuries, therefore choosing parenteral nutrition over oral feeds?
So first of all, by the time you go for parenteral feed, it must be that is the only option that is available. So if a patient is not able to take adequate feeds, if a patient is able to feed orally, first of all, we need to look at how can we be able to enrich the foods that the child is getting, so that the small amount we're able to maximize in terms of kilocalories. So of course, we want to minimize the amount of pricking that we give some of these children, because they go through a lot of pricking. So we use parenteral when we see that the enteral route is can't be used completely.
Perhaps to add on to what Barbara has just mentioned, it would not be in order for you to conclude that simply because the patient is exhibiting mouth sores, then now the whole gut is involved in it. Because remember, it could be localized. Yeah, the same way you could even be having rashes on your skin. Doesn't necessarily mean if you're having rashes on your forearm, it generally means your whole body has the skin rashes. That it might be an example that I might be able to use. So it might be just localized to the mouth, plus also it also depends, are you describing oral mucositis as the mouth sores? That is what now also, it depends now also the nature. So clinically you have to examine the patient, that's number one. Number two, after you've examined, then I'll be able to pick out in terms of the sort of mouth sores you're describing, what would you perhaps would be attributing them to? Because remember, mouth sores would come in different forms and shapes, and depending with the cause, perhaps you would be describing herpes simplex virus as opposed to now the mucositis as a result of the radiotherapy or the chemotherapy treatment in your patient. So a clinical evaluation would be mostly relevant in that particular individual in case you are making a decision on whether to go enteral or parenteral. So you have to do a thorough assessment on that particular patient. Thank you.
Okay. Okay. We thank you for that. There's another question by Halima. She's saying, to her knowledge, sugar feeds cancer cells, making them more aggressive. How about honey, which I see is a remedy, as you recommended earlier, in the management of mucositis? What is your take on the same?
So first of all, we need to remember this child is still growing, and sugar is a carbohydrate, so this child still needs energy. That is the first of all. It's like saying we have processed sugars, but at the same time we have other sugars that are beneficial to the system. So first of all, we encourage foods that are beneficial and not
more empty calories.
So when it comes to sugar cells feeding the cancer, remember we have healthy cells that still need energy. The child still needs to be able to grow. So that energy, first of all, is required. Then second of all, remember this child has chemo, and the role of chemotherapy in this child is actually to deal with the cancer. So how do I do this? So one of the things that you will find is affecting your child is some of the effects of chemotherapy. And this chemotherapy is what is going to help the child. So for you to just ease the pain on the child is for you to be able to use the honey. Yeah, to be able to use the honey.
Just an addition to that, in terms of, I think the question the person who is asking perhaps would need to clarify what they mean by sugar. Because do you mean sugar in food, or do you mean the processed sugar that you are making an assumption? So here, making an assumption, you're referring to the added sugar. But then again, if you're to compare processed sugar with honey, even if you're to look at how honey is, honey also, if you're to read even in terms of the research, it has some bit of antioxidants, and it has also other aspects to do with some bit of anti-cancer properties in their composition, which would differ from processed sugar. So perhaps the clarification would need to come out clear in terms of which part of sugar you're referring to, because in as much as we are concerned, even the food that you eat would still have the sugar in it. So you can't say you'll starve the patient simply because your concern is just simple about sugar, because ideally the food you eat contains the sugar. So unless you're saying you starve the patient so that you starve the cancer cells, that I believe would not be ethical, and it wouldn't be the right thing to do from where I'm sitting. Thank you.
Maybe to add again, maybe sugar is just a form of carbohydrates. Just before we consume, but once we consume, when it's in the bloodstream, it's now glucose, and that is actually providing energy for our daily activities, and also for our systems to work, especially the heart, the kidneys, and the brain. And therefore, when you say you want to avoid sugar, you cannot get energy from other foods, which are actually expensive. When you take like proteins, the form of energy, the waste, you take fat as a form of energy, it's expensive, and also the products. For instance, ketone bodies that results when due to incomplete metabolism of fats will have an adverse metabolic effect on your system. Thank you.
Thank you as well. We will take another question by Leah. I don't know, she was asking about square feet. I don't know where that is in relation to.
I think
Maybe the question was, how do you determine the glutamine?
Or the glutamine calculation. So normally you calculate it 2 grams per meter square of the child. Okay, thank you. So Edward is also commending the presentation. So in addition to that, he's also asking some several questions. One being, how can parents and caregivers ensure adequate hydration in children undergoing treatment? The second one being, is there a role of appetite test in children with malnutrition and cancer? That being, can certain nutrients or supplements help alleviate treatment side effects or boost appetite and weight gain in pediatric oncology patients? The other one is, how can parents and caregivers support a child's nutritional needs during the transition from treatment to survivorship? And the last one is, are there any special nutrition considerations for kids undergoing stem cell transplant? So we'll start with the first one. How can parents and caregivers ensure adequate hydration in children undergoing treatment?
Maybe
We can answer that one. We can use natural herbs
to
flavor the water so that you can take more
of it.
rather than taking plain water.
We
You
can
can
add
add
something
something
like
like
ginger,
ginger,
you can add
add honey,
you
you
can
can
add
add something like rosemary so that you can
improve
improve.
the taste.
And when the taste is improved, children they will be able to take more, they'll be able to hydrate.
Just to add on that, we were told earlier that we are reviewing the patients. It's not supposed to be standalone. Just as Kimboy has mentioned, we are supposed to look at the biochemical parameters, meaning the blood works. It is very essential for you to assess. Probably you receive lefties before you make judgment on the type of herbal use, because sometimes you might find electrolyte derangement and it might be contraindicated to actually use herbal plants or means or the ginger. So it depends how the patient is actually presenting. That will give you a way, will get which how to flavor the water so that you're able to hydrate. Thank you. Okay, the other question is there a role of appetite test in children with malnutrition in cancer?
Yes, we can use appetite test.
We need to also look things will vary from day to day. So one of the things that is very important is for you to be able to be doing daily in terms of the feeding. You need to also be able to the total intake, which is why looking more at the food record and also the 24-hour
tends to give you a better
idea in terms of the appetite of the patient.
patient.
Also, I think just as she mentioned earlier that sometimes when you're determining the appetite, this test of this to determine how much the child or the patient is able to consume. If the child is not able to consume 75% of meal served, then probably you can consider interval feeding. If probably biochemical parameters are okay, especially platelets and INR, so that you're not able to start fixing routes for interval feed, or you have assessed the same. Okay, so that will be maybe just to add on that. Additionally, we have another question that was, can certain nutrition supplements help alleviate treatment side effects or boost appetite in pediatric oncology patients? Okay, in terms of,
let me answer it in parts. Nutrients
supplements that can alleviate treatment effects, there are just some that work, such
such as the one
about the cryotherapy, using the honey, and also
trying to use the
vitamin to be able to
give them the methotrexate side effects.
So most of the side effects you find, there's no one thing that you can be able to give them that can prevent.
But now we try to manage them based on how they present themselves.
Then
when it looks at the side effects of able to boost appetite
and weight gain. So for us to be able to boost appetite, especially for these oncology patients, we find that most like appetite stimulants will not work. So sometimes it's good, first of all, to be able to make sure that all our patients are on multivitamins to be able to support at least the vitamins and minerals in the system, which can also affect appetite. And then sometimes, and in some cases, they may be able to use steroids to be able to boost the appetite, although it's not common practice. Then we have the for weight gain in pediatric oncology. First of all, the only way you'll be able to achieve weight gain is to find out how much is your patient taking, how much do they require in order to be able to gain weight, and for you to be able to tailor your intervention in a manner that you know you're providing excess calories. If you want your patient to gain weight, you need to give at about 120% of their caloric requirements for them to be able to gain weight. So you need to tailor plans that are able to provide at least 120 in terms of kilocalories, also in terms of the total protein that your child is taking.
Thank you. The other question is, how can parents and caregivers support a child's nutritional needs during the transition from treatment to survivorship?
First of all, I think you as the healthcare worker need to make sure that you've been able to inform the patient so that first of all, they're able to make, not the patient, the caregiver, and of course the patient is then for all the children, so that they're able to be able to adhere. So the most important is even in the course of treatment and even if possible after treatment to just make sure that you're doing some nutritional follow-ups in terms of the children so that they may be able to that would help.
Well, the biggest key thing here would be even prior to the child being initiated the treatment, you see the parent has to be on board. The parent, you have to work with the parent or the caregiver so that now they understand what is their role in the management of the child, in as much as now the child is getting the treatment itself, so that they know what are the aims of the treatment. That should be number one. If at all the parent does not understand what role they play, it simply means whatever you're doing might all be in vain, because they need to understand why are they there, how can they be helpful to enable the child get the best treatment and to get now the best clinical outcomes at the end of the day, because they're not just there as parents, they have a role to play. They're the ones who are going to encourage the child. They're the ones who are going to work together with the child, because remember, the child is familiar to the parent much more than to the clinician. So they might end up leaning towards the parent for support much more than the clinician. So the parent needs to understand what role do they actually come into play when it comes to the management of the child. If they don't understand that role from the word go, it simply means you can't start that at the end of the transition period. So it needs to start even way before the treatment begins, so that now all of you know what is the target at the end of the day, what is the goal, and where are we headed, so that now you can be able to forge forward in terms of which path do we follow, which path do we use.
Thank you for that. And then the last question is, are there any specific nutrition considerations for kids undergoing stem cell transplant?
Maybe number one, you need to know that with patients who have stem cell who are set to undergo stem cell transplant, one, you need to consider the nutrients. That is, and also their functions in the body. And the larger part of it is the protein and the carbohydrates that provide calories. Majorly, protein should be given between 1.5 to 3 grams per kg per day, so that they can also repair the tissue and also affect the immunity positively. Also, because of the nutrient requirements, calories requirements, based on also some stressors, also catabolic effect, you need to increase nutrients up to 3 times of what the patient is required. You also need maybe hydration of this patient, so that you can prevent the side effects of the treatment and also its losses. Nutrients of interest, the micronutrients, these are vitamins and the minerals that you need to actively check and do your calculation well. Also, maybe you can give some probiotics and also the anti-inflammatory nutrients. So that is maybe omega-3, omega-6, so that maybe they can affect positively the inflammation rates as a result of the treatment.
Well, perhaps just to add as a summary of that, remember, as you're doing now your stem cell, there's also an increased risk in terms of infection, aspects to do with either the graft versus the host disease. So you have to be very, very keen in terms, even in terms of your monitoring. So you have to be on the lookout, and you have to be able to support, because remember, you are likely to get most of the nutritional challenges from mucositis to the altered changes in terms of tastes, infections themselves, so, and also altered metabolism from perhaps the high dose chemotherapy that the patient might be on. So it would be prudent for us to be very specific in terms of what approach we're using whenever we are managing patients who are undergoing the stem cell transplant.
Thank you for that. Thank you, Madam Mercy Barucho, for joining us today. She has commended you for the very informative presentation that is crucial for supporting child growth and development, managing treatment side effects, and potentially improving treatment outcomes. Thank you for the commendation. And then we have another question by Julius Clinton. How should nutritional requirements be adjusted in pediatric oncology patients who develop hypermetabolism and protein catabolism during intensive chemotherapy?
As I had mentioned, first of all, you need to look at what will be determining whether our patient is getting adequate nutrients or not. Then again, if your patient is not getting adequate nutrients or they are highly catabolic, then you want to increase your nutrients in terms of protein and also in terms of caloric requirements by at least 120% of the caloric requirements that the patient requires.
Okay.
Well, perhaps just to add on to that, remember, whenever you're mentioning the aspects to do with hypermetabolism or protein catabolism, in these aspects, there is more that is happening on the background than what you're seeing. Because ideally, that tells you in terms of aspects to do with the immunomodulators, or aspects to do with certain things like the cortisol, the glucagon, and the catecholamines. You see, they'll end up affecting, and then now that means at the end of the day, whenever you're talking about the catabolism bit, it simply means you've already kicked in the scenario of gluconeogenesis, and the effect is usually increased and related to the magnitude of now the problem, which perhaps you'll see you might be ending up having challenges with the aspects to do with hyperglycemia, lipolysis, water retention, or so you need to be treading carefully. And depending now with whatever the markers that are showing you, where are you, you need to actually be very, very cautious as you are managing this particular patient. Because remember, as lipolysis is happening, it can lead to ketone formation and possible acidosis in your patient. And since there's increased breakdown of the proteins, then it can lead to increased production of urea in your liver that might also be needed to be excreted in the kidneys. So the elevated cortisol levels sometimes suppresses the effectiveness of the immune system, and hence you can get they are more prone to getting infections. So you have to be on top of things to evaluate all the body systems as you're managing them. Thank you.
Thank you very much, everyone, for joining us today. We are grateful for your presence. We will share the next webinar in the coming months. Looking forward for you joining. Thank you. Have a good afternoon.